Dear panelists, esteemed audience, welcome to the side event titled Building Inclusive and Long-Term Policies for Crisis-Affected Regions and Migration. My name is Merve Gizem Eroğlu, and I have been working as a Global Development Specialist at IFGC for almost 3 years. And I am delighted to be with you for today as your moderator for this session. First of all, I would like to extend my gratitude to our main organizer, the Sudanese Green Crescent Society, as well as our esteemed co-sponsors, IOM UN Migration, Ghent University Institute for Social Drug Research, Turkish Green Crescent Society, and Conectados per la Vida for their support in making this event possible. Today's discussion will focus on the intersection of forced migration, mental health, and substance use, particularly in crisis-affected regions. In 2024, over 120 million people were forcibly displaced worldwide. And it's crucial that we develop inclusive, long-term, and trauma-informed policies to address the unique challenges these populations face, as forced displacement often leads to severe trauma, PTSD, and anxiety, which increase the vulnerability to substance use. We are honored to have a distinguished panel of experts who will share their insights from different regions and disciplines. Our session will feature 6 speakers, and each will have approximately 7 minutes for their presentation and 3 minutes for Q&A session. Without further delay, let's begin our session with our first speaker, Dr. Rıdvan Yahya Ibrahim. I guess it seems there may be an issue with the internet connection, and so it's all right for all of us. We can move on with our session with our second speakers. Mr. Guglielmo Cecchina from IOM UN Migration will join us with his presentation on alcohol and substance use among migrants and displaced populations. Mr. Guglielmo will share insights from IOM's programs on substance use among migrants and displaced populations, drawing from real-world applications in resettlements and displacement settings. Mr. Guglielmo, you will have 7 minutes for your presentation, and the floor is yours.
Thank you very much. I'm very grateful for the invitation that you extended to me and to the organization to participate at this side event, because obviously, the issue of alcohol and substance use among migrants is one that is very important for us, and needs attention. Also, because very often it builds on the negative narrative of migrants. So very often, the issue that migrants are considered to be more a risk to substance and alcohol use or abuse, brings to a negative perception of them. Is this true? Is this not true? Is what I'm trying to now unfold with my presentation. So I will share the screen. I hope you can see it. Can you confirm?
Yes, we can see your screen.
So I'm not spending but I cannot, it seems that I'm unable to move the presentation for some reason. Let me see. Okay, so now solved. I'm not spending too much time. IOM is the International Organization for Migration, is an intergovernmental organization, part of the UN system, the United Nations Migration Organization, with 170 member states. We have a mental health and psychosocial support unit within IOM that is present in this moment in 113 countries' situations, looking exactly at the mental health and psychosocial well-being of migrants in different situations. I will stop there, so there is no need for more. Where do we intersect substance use disorder in our programming? Assistance to victims of trafficking. Victims of trafficking are also migrants that are forced to migrate, even though they don't come, from war situations, where very often drug use is an issue. Assistance to vulnerable migrants in general. Usually, one of the factors of migration, of vulnerability of these migrants is actually alcohol or substance use. Assisted voluntary return and reintegration. So when a migrant's plan fails and we help the migrant to return back to their countries, voluntarily, obviously. This is also an issue in which we encounter a lot of problems, a situation in which we encounter a lot of issues with alcohol and substance use. Then resettlement health assessment is a moment in which we make health assessment to migrants, actually to refugees, who are refugees in certain countries and are resettled to a third country that is able to basically host them. This is forever, for permanently. This is by instance, to the US, to Canada, to Australia, but also to many European countries. Then obviously, since we do this health assessment and usually alcohol and substance use is considered to be an exclusive condition for some of these resettlement process. So people are excluded if they are under the influence. So this means that, we have quite a good start, in that respect. Then there is the reintegration of former combatants, where very often, issues of drug use, as you were saying, PTSD is really, more than, in forced migration, is really an issue among former combatants. So it's quite strong in that setting, camp settings and transit settings. What the general statistics, I didn't bring all the study here, but studies are inconclusive. So we don't know if migrants in general, so migrants is a very all-encompassing, terminology, but we don't know if migrants are more at risk of alcohol and substance use than the general population. The research is skeletal. There is not enough research, to corroborate this. Research is very population and context specific as it should be. So if this population in this specific country, in this specific context, with this specific migration history, so it's difficult to universalize, to all, extend to all migrants worldwide. And then we know that cultural perception of drug use differ by context, as sometimes, and this is a problem that we face also, differ the quantities that differentiate use from abuse, so a disorder from, a normal use in certain cultures, of certain drugs. I'm talking about alcohol, in some cultures, but I'm talking also about, for instance, the use of cat, among certain populations in the Arabian Peninsula. And so, among forced migrants, the one that you were talking about, humanitarian camps and camps-like setting, this is the one in which I'm focusing because IOM is the lead of, together with UNHCR, of the camp coordination and camp management cluster, in the humanitarian setting. There might be an issue there. You talked about it, traumatic experience, comorbid mental health disorder that are not being treated. So as a coping mechanism, instead of having, pills, then, you use, other substances, acculturation challenges, and also social and economic inequalities. Also the issue of waiting, very often in camps, people are not allowed to work and they stay in this empty space, for a long, long period of time. So there is an empty living space to fill. The highest quality prevalence estimates that we have, also here the research, as I said, is skeletal, not very good, and so on, but the one that we have that are the best, we see that there is a difference between what happens in camps and what happens in nearby communities. While we have 17 to 36 in camps, so depends also on the camp, so it's a very big variable, if you see, but as you see, while it goes to 4/7 in the respective community. So we see that it's probably 4 times, as big. So there seem to be an issue with these studies that, however, as I said, suffer from all the limitations that you were saying before. We have also 8 studies that conducted multivariable analysis, and they say that basically being a male, trauma exposure, and symptoms of mental illnesses were obviously correlated of substance use in those humanitarian settings. So trauma exposure in the past, symptoms of mental illness, comorbidities, and being a male, so being a male and not a female. These changes among victims of trafficking and accompanied and separated children, because as I was saying before, victims of trafficking, so sexual and labor exploitation and exploited and accompanied separated children usually, among all our studies, have higher incidence, of drug and substance use, alcohol and substance use than all other migrants, at least. That's what we can compare. Why? Because drug is used as a form of coercion. Drug is used as a form of performance enhancer and as a form of debt bondage, and these three work together, basically. You use drug at the beginning to coerce the person to leave, then you use it, you force the person in certain works where they need to use drugs in order to be performative as you have requested them to do. Then since they need drug, you provide them drug, and then you keep them bound with the debt bondage. So this becomes a real mean of organized crime, so that's how it works. Our resettlement support, this is where we have the most accurate statistics, because actually we look at individual. This is in Asia, so I'm not talking about all the countries. It's in 2024. We had we checked, we had 15,993 medical assessments performed. On these, only 106 individuals suffer from from alcohol and substance use disorders. This is that 0.66%, So it tells us that also within this population, there is a difference between the ones who are stuck in camps, and the ones who have a perspective in life, so something to move forward, with their, who have a recognized status and they can move forward with their life. Just, to make, it doesn't seem to be a lot, 0.66%, but it's almost 1/4 of all those assisted with psychiatric care. So if you look at the people, assisted with psychiatric care, it becomes a very significant proportion, It's almost 1/4. And among those, we have 75% of alcohol use disorder, 25% of other substances being mainly cannabis or methamphetamines, But so to conclude, because my time is quite limited, migration and displacement can expose individuals to threats, that make them more vulnerable to substance and alcohol use. There is scarcity of evidence, as you say, the studies that are presented, you see, there are very few and very not spread. There is a limited coordination and referral system among actors that impedes access to rehabilitation services. On the other side, we cannot have standalone substance rehabilitation services only for migrants or standalone rehabilitation services in general, because these augment enormously the stigma that migrants and people with conditions are already facing. So we have to integrate these services into primary health care, but also other services that usually are offered to migrants, in a multiplicity of settings. There is also paucity, as you probably know, of mental health specialists in the area of substance addiction management. This becomes extremely serious then in locations where usually displaced people are living that are not central, in the periphery, of the countries, and so this is a huge gap that we'll have to try to cover. And then there is very limited availability of comprehensive community-based rehabilitation packages that will make let's say, the treatment of people on the move, the rehabilitation of people on the move possible, because only in the community this can happen, especially if they are still on the move. So if you block them, let's say, in a rehabilitation center, they risk to be blocked somewhere while the family and community move on to other places. So the recommendations are very easy. MHPSS curative preventative rehabilitation services should be based on evidence, so we need more research and more assessment. It's better not to have separated services due to stigma and discrimination issues, as I was saying before. We have to build trust with those community and have their buy-in in the promotion of initiatives, and rehabilitation models, that work for everyone. These include also that the services that exist, when they exist, should be language aware. So basically, they should speak the language of the main migrant communities that are present in that territory. We have to build the capacity of all actors involved in substance use management or in psychiatric care, by instance, psychiatric nurses, that can do a lot in this respect, but also in other sectors, that are the ones where migrants might be more keen and more inclined, to show up at. This means humanitarian assistance, faith-based organization, users association, security systems, because a lot of migrants enter, in contact with the security system, being it the asylum system or, the border management and so on and so forth. So all these professionals should be trained in what to do in order to refer then to services that, as I said, are community-based and accepted by the community, and they are not specific for them, but where they can be easily integrated. All this based on research and, let's say, evidence, that we need to create collectively. I hope I didn't steal too much time. Thank you very much.
Thank you, Mr. Guillermo, and especially your emphasis on importance of multiple services working in the partnership with the community to deal with addictions among migrants was very valuable. So thank you again for your presentation. Now we can move on. Our next speaker, Dr. Charlotte de Kock from Ghent University, will join us with her presentation on substance use among refugees in Europe, the urgent need for equitable prevention and treatment. Dr. Charlotte will examine how migration-related stressors contribute to substance use and mental health challenges, with a focus on the post-2016 European migration experience and prevention strategies that can be adapted for future crises. Dr. Charlotte, the floor is yours. Thank you.
Thank you, Merve. Thanks for having me. It's very nice you're organizing this side event, and I think it's very necessary also to do this at this particular time. So no PowerPoint for me, as 7 minutes is very short. First, some context. So by May 2024, about 1 in every 100 world inhabitants were forcibly displaced. The majority of this population is internally displaced outside of Europe. Nevertheless, the numbers of applicants of international protection, recognized refugees, and other types of forcibly displaced populations are growing in Europe too. So an increasingly hostile political climate towards migration, advocating for the human rights for these populations becomes ever more important, in this increasingly hostile political climate. In Belgium, for instance, the lack of reception housing poses a serious threat to the health and mental health of incoming, mainly male applicants of international protection who land up in the streets of Brussels, vulnerable to all aspects of street life, including substance use as a coping mechanism. Brussels NGOs alert that the use of, for instance, Lyrica or pregabalin as self-medication and to keep warm and be fearless when sleeping in the streets is becoming increasingly systematic. European studies generally demonstrate lower substance use among recently arrived migrants, whereas substance use and the related problems and disorders appear to increase at population level after a longer residence stay. So substance use then becomes more influenced, as already demonstrated by the previous speaker, by the availability of substances in combination with post-migration factors, including the reception conditions, such as housing and the duration of the asylum application procedure. Moreover, pre-migration factors, such as war affectedness and trauma, can be linked to substance use. Although the theoretical link between trauma, post-traumatic stress, and substance use needs to be further theorized and studied in these populations in Europe, it is abundantly clear that displaced populations are at an increased risk for substance use, and that societal conditions have a significant impact on its occurrence. In an overview on substance use among forcibly displaced populations, Professor Ezar and colleagues identified that the self-medication hypothesis, the social stress model, and changes in social control, also the availability and accessibility as reasons for substance use in these populations. They identify social norms, social networks, access to services and food rations, and the hope for resettlements, especially in camp settings, as protective factors. I've been studying these issues for the past 10 years at the Institute for Social Drug Research at Ghent University and in close collaboration with partners such as the European Drugs Agency. Considering the short time I have, I will limit my talk here to two main topics: identifying staff needs who work in European reception settings, and 4 concrete recommendations to deal with support to substance use-related problems in displaced populations in Europe, starting with providing housing. Secondly, access to the health system. Third, training for reception staff. And fourth, foreseeing safe environments and evidence-based prevention and early intervention in the reception setting. When I first started doing research on substance use and migration, I focused mainly on people who lived and worked in Belgium for decades and who often had also been born in Belgium. For instance, people with Turkish migration backgrounds. These people from first, second, and third generations experienced to this day discrimination in education, housing, and the labor market, which is reflected in their general well-being, mental health status, and unfortunately also in substance use. One of the major barriers for these populations was that residential substance use treatment in Belgium works discriminatory based on language. If you do not speak the language, or if you are deemed not to speak the language, you will likely not be able to enter residential psychiatric hospitals in Belgium. The situation remains unchanged and is worsening. In times of austerity, waiting lists become longer, and the lists of informal exclusion criteria become longer too. In my more recent research for the Belgian Federal Agency for the Reception of Asylum Applicants, I see that the situation for applicants of international protection is also worsening. If they are treated for substance use-related problems residentially, it is mainly limited to a few days in a crisis unit, often without proper follow-up. In a research project I conducted with the European Drugs and Asylum Agency about reception staff needs in terms of substance use-related issues in Europe, this access to substance use services was equally identified as the largest problem by many respondents working in the reception setting across the member states. So this is the second recommendation. There's an urgent need to improve access to substance use related and mental health services for these populations, removing all exclusion criteria related to the rights to the full health system, as well as language-based exclusion in Europe. Also, over half of the surveyed staff in this European study reported insufficient knowledge to address substance use related issues effectively. So recommendation 3 is training is needed in areas such as prevention, early intervention, treatment, and harm reduction, such as naloxone usage, and managing other drug-related challenges such as aggression in the reception setting. Both the European Union Drugs Agency and the Asylum Agency are currently undertaking efforts in this domain by identifying promising practices in the field and offering training to reception staff. The Belgian Reception Agency too is supporting staff in this domain. Lastly, recommendation 4, in line with international literature, but also considering both the current inaccessibility of residential services, as well as the move in European substance use treatment towards recovery-oriented, community-based, and outpatient treatment, it will be key to focus in Europe on prevention, early intervention, and post-treatment follow-up in the reception setting itself. Offering a safe environment with prevention interventions adapted to age categories and backgrounds, and having staff that is sufficiently trained in, for instance, motivational interviewing is key to address substance use related factors and its underlying causes. So I'll briefly repeat my 4 recommendations. First, housing for incoming applicants of international protection. Second, access to the full health system, including mental health and substance use related treatment and other services. Third, training for reception staff. Fourth and last, foreseeing safe environments and evidence-based prevention and early intervention and post-treatment interventions in the reception setting, so not referring to outside the reception setting. I cannot but end this talk with repeating one overarching call to keep on advocating for the human rights of displaced populations in Europe, with specific attention to decent housing and access to health, as their absence underlie negative mental health, substance use, and thus, in the long run, affect the society as a whole. Investing in these human rights will even prove cost-effective in the long run. Thank you.
Exactly. Thank you, Dr. Charlotte, for highlighting the European context and the need for equal treatment strategies for migrants, especially the language barrier is very critical, as you already said, and overcoming exclusion criteria was very important. Thank you again. Next, we are pleased to hear from Ms. Gracie Maciel Perejo from IFRC Regional Office for Europe and Central Asia, and will join us with her presentation on humanitarian approaches to mental health and substance use among displaced populations, a comprehensive approach in Europe and Central Asia emergency responses. Ms. Gracie will provide a practical example of IFRC's emergency response approach in crisis settings, including Syria, Greece, and Ukraine. And these examples will emphasize the impact of displacement on substance use and mental health. Ms. Gracie, you will have 7 minutes for your presentation, and the floor is yours.
Thank you, Merve, and thank you for this opportunity. It's extraordinary to see many organizations and colleagues together here to speak about a specific issue that we need to raise our voice and be the voice of our migrants, especially for the people with mental health issues and as well that are consuming substance due to many reasons that they are need our support. Saying that, I'm gonna try briefly in my 7 minutes to try to address these 3 aspects, okay? Intersection, and our actions and community-based health interventions, and then a call how we can work together to make that the policies and decision makers really include a comprehensive approach, okay? When I hear before the IOM college and the doctor previously to me, I don't want to sound repetitive, but it's important that in my role in IFRC that I am based now in Europe and Central Asia, but the last 15 years, being member of IFRC, the International Federation of Red Cross and Red Crescent, I have the opportunity to serve in 88 countries and work with the 88 national societies, but now we are more focused in the 53 that is Central Asian and Europe. And something that I can see is also demonstrating based evidence is that all the forced displaced people have in common is many things, but one is the suffering that is there, okay? So this suffering, it's a cognitive and emotional component that many times the displaced people don't know how to deal with that. Why? Because also it's a social and anthropological aspects that it's related especially with culture. Let me explain better, no? When people displaced, it's coming from countries when mental health or any emotional burden, it's stigmatized. It's more difficult for them to be open and speak about their issues, okay? So, and then also culturally, some negative coping mechanisms like the use of substance, it's culturally accepted and it's the way that they adopt to cope with this suffering. Okay, so we have, as you can see, previous aspects that during the displacement, it's gonna be probably reinforced and it's gonna move people to abuse more of this substance. Okay. But saying that, let me go a little more there, okay? When we speak about the intersection between the forced displacement, mental health challenges, what I can say briefly, because I can speak hours about this and even years, because it's a extraordinary topic that we can speak a lot. I can say, yes, there is an intersection, and we need to be really mindful, all of us, when we speak about that. Briefly for the ones that are connected, and allow me to take my notes because I don't want to lose any thoughts here, okay? Why is an intersection? Because trauma during the displacement. We say people before the event, the crisis or the conflict, they have already in their normal life challenges, and plus this stigma surrounding mental health. They don't know how to deal with their emotions because there is also a gap in the emotional literacy. I used to to use this terminology. It's a gap in emotional literacy. So people used to consume alcohol to forget all the problems, and during the trauma displacement, this can be increased because it's the way that they cope, and also it's an imitation, it's a social thing to be accepted. So we need to be really careful and mindful that this is happen with the people that is forced to displace. Then coping mechanisms, as I mentioned, we saw, for example, in Greece, in accommodation centers, how especially men used to use a substance to deal with the suffering. So this is a coping mechanism that they imitated and can be increased during the displacement. Mental health crisis. Here, it's an attention for people that has pre-existing mental health conditions, and throughout to the journey and the crisis event can be exacerbating more and more. And here, statistics say that 1 in 5 people displaced or in front of these kind of challenges is going to suffer a mental health condition if they don't receive on time support. Okay, so as you can see, it's many things that are accumulative. And at the end, we enter in a vicious cycle. Why? Because they don't have access also to mental health services. They are using this coping mechanism, and there is the trauma and a big gap in how to access to services, and it's a negative thing. But please take in mind at the end that is a real intersection there, and we need to be really focused on that. So, but the good thing is that basing evidence in IFRC, the national societies, we are implementing a comprehensive approach based in evidence with several tools in the frame of MHPSS, that is mental health and psychosocial support, that are really focused, at least in these 4 aspects that my previous colleagues also mentioned, that trauma-informed care, this is really important. And as everyone needs to be trained, for example, in a simple tool that is PFA, that is a precursor or the first step for trauma-informed, and everyone is sensible to address and support that person that is dealing with this substance use or abuse in how to express what is happening with them. Okay, integration and mainstreaming is really important. It's not health without mental health. All the services also needs to consider mental health support and psychosocial support. It's a time to change this, that is not an essential health services that we need to provide, and it's not a luxury. It's something that we need to consider in our emergency responses and in a daily work for integration of the migrant and displaced population in the countries that is hosting them. And then community approach and support. This is important that they be also co-participants in the creation of the responses, and we have successful histories about that. Yeah, and also this is gonna help in this approach, integrating communities to break the stigma that is surrounding to the people that it's substance use, because you know how they are stigmatized. Plus, if they are having any mental health condition, it's more and more. Just this community approach, it's really important, community engagement and accountability, and no less important referral system, because we will see our national societies, for example, they provide this support across a framework that we're gonna see. But here I present to you, I don't pretend to navigate on that. It's just that I want that all of you be aware. We're gonna share the link of these documents, that we have clear frameworks in how to address especially this burden in the mental health and also substance abuse in our responses. Then I'm gonna provide more details. I'm not gonna also stop here, because I want to speak more about case studies that be interesting for all of you. But look, here you can see the pyramid that I say. Our national societies across the globe, and here in Europe and Central Asia, we provide these services for the migrants and displaced people affected in all these layers, depend on their capacity. But for us, it's mandatory to address the mental health and psychosocial needs of the displaced people, because it's the way that they are gonna cope with all the burden that they have. I know that time is passing, but here I have these beauty photos, okay? Some examples are at the first layer of the pyramid is this humanitarian services point that we have across, for example, the migration road that is activated during the Ukraine response at the acute phase, or when the Syrian refugee crisis explode also in Europe. We have it there. That is a basic healthcare, but also is psychosocial support, and especially psychological first aid, that, as I say, is the first trauma-informed step that help people to speak. Everyone is trained, and this is very important. Then you can see the photo with the two ladies down. It's, again, psychosocial support and mental health. Women also are dealing with substance use, especially in Europe, because the consume of alcohol, it's increasing more. In men, we saw more for all the kind of drugs, but it's a call for be mindful about that. Then we have, for example, in refugee camps, previously named like this, a holistic approach, including psychiatric, psychologists, and referral system. And we have a clear example in Greece again for accompaniment services, because sometimes the migrants are not having understanding on the language, and we need to guarantee that when they go to the health services, someone is with them and translate it and guarantee to access really to the services, okay? Last thing that I want to highlight today is a call for action. We have a policy to address the mental health and psychosocial needs of the affected population, as well as resolution that was signed also for all the countries under the Geneva Convention. And I think this forum, it's a good momentum for call for action and remember our commitments, because our government signed also this resolution that I'm gonna share later. And in summary, it's really important that we don't forget to have a comprehensive approach, and it's a call for action to more than ever to mainstream mental health and psychosocial support in any response that we have, and be the voice of the most in need, that are people displaced and forced to leave their countries. Thank you. Open for any questions. I'm sorry for extend my participation.
I guess Ms. Charlotte have a question.
No, my apologies.
Okay.
Thanks
No
for
worries.
an interesting talk.
No worries, you're welcome. Miss Crazy, your presentation covered truly valuable topics, especially the integrated approach to mental health and substance use services, trauma-informed care, and community and social support, and the routing system, all essential elements in creating a comprehensive and effective intervention strategies. Thank you for your presentation. And these insights will have a significant impact on both professional practice and also individual care. Thank you again for your sharing. Let's continue with Dr. Alexander Kisi da Silva from Conectados para la Vida. He will join us with his presentation on social and structural factors affecting substance use in displaced populations, insight from Venezuelan migration to Brazil. Dr. Silva will discuss how social and economic instability shapes the substance use patterns, using Venezuelan migration to Brazil as a case study. Dr. Silva, the floor is yours. Thank you.
Thank you. It's an honor to be here with you today to share a little bit about what you are facing here in South America. We have this problem in Venezuela since 2015, and Brazil has been the destination for Venezuelan refugees. We have more than 8 million Venezuelans in the world, and we started to face this problem in 2016 with overload of public services, and we face a lot of problems like vulnerability and problems with indigenous people. And as you can see here, we have this border from Pacaraima. It's one city in Brazil. It's the city where most of the Venezuelans enter in Brazil. And then after they go to Boa Vista, which is the capital of this Roraima state. And in 2023, we have more than 192 Venezuelans entering Brazil, and Brazil is the fourth country worldwide hosting the most Venezuelans, and we have up to
Sorry for interruption, but your slides are not moving. Yeah.
Okay, now
yeah.
you can see.
Yes, now we can see.
And Brazil, it's we have more up to 200 people across the border each day, and Venezuelans we have in Brazil have entered since 2017 more than 1,000 Venezuelans here in our country. And we have many problems like social vulnerability. Many migrants struggle with housing, food, employment, despite having high school and higher education. We have problems with crime involvement. Many of these migrants became involved with criminal groups such as PCC, which is a group from Rio de Janeiro, and but they are working in the border too. And we have prison overcrowding. Roraima prison population doubled in 6 years. By 2022, it was 80% above the national average, as you can see in this table here. By 2022, the Monte Cristo Agricultural Penitentiary housed 226 Venezuelans inmates, highlighting the involvement of migrants with criminal factions. PCC has extended in the region and recruited migrants, including Venezuelans, often due to the lack of opportunities and social vulnerability of immigrants in the border region. This contributed to the strengthening of the faction in northern Brazil. We have problems with mental health challenges, limited access to services, language barriers. As Dr. Cholat said, in spite of speaking, we in Brazil speak Portuguese and they speak Spanish, but it's similar, but we face many problems with language. And administrative issues remain significant obstacles. As you can see, the Pan American Health Organizations has some initiatives in Brazil, in Roraima, to strengthen mental health support and community support networks. In this study here, you can see that migrants, Venezuelan migrants in United States face problems with drugs and family support. We have other study here in the United States showing that Venezuelan migrants are drinking at higher rates than their Hispanic migrants peers. And we suppose it's the same in Brazil. And we have this study here with immigrants in Brazil and Colombia. I don't know if it's small here, but you can see the words that in the interviews, what most they say, like during the interview, like health, like money, like discrimination, many of these these words here, as you can see. What is being done in Brazil? We have this welcome operation in partnership with the government and NGOs to provide humanitarian assistance and psychological support. We have some NGOs working with harm reduction, but we have many challenges like funding shortage for NGOs, as we know in this year, and many barriers to integration, limited resources for social integration, hindering access to healthcare and legal services. This operation, it's very interesting because we started to monitor Venezuelan population with data collection, coordination of humanitarian and development assistance, and support from the private sector and civil society for the local integration of Venezuelan, and humanitarian assistance services like shelter, meals, hygiene kits, Portuguese classes, and basic healthcare, communication with family members, and regulation and documentation, this processing of the regulation requests, and interiorization program with this very interesting, with the participation of many Venezuelans volunteer, and they go to another states in Brazil, like for example, I live here near Argentina, and we have this many Venezuelans working here. Many people went to São Paulo, for example. As you can see here, this program with interiorization across the years. We have social assistance for Venezuelans, like for other Brazilians. We have this conditional cash transfer program aimed to reducing poverty by providing financial aid and to low-income families. And the conditions are the beneficiaries must ensure school attendance for children and other two vaccination schedules, because we, for example, don't have many, we have a very good vaccination program in Brazil, and we face some problems with diseases that we had already eradicated in Brazil, and now we need to vaccinate these people to don't spread this kind of conditions. In conclusion, with this healthcare access, Venezuelans migrants receive a health card ensuring free medical care. Like for all Brazilians, we have free medical care in Brazil, and we do vaccination campaigns. We do this welcome operation that provides shelter, jobs, and legal documentation. We have integration barriers like language difficulties and job market competition, strain of infrastructure in the border region, and we call for international support. Brazil remains committed but need global cooperation for sustainable solutions. Thank you for listening.
Thank you, Dr. Silva, for highlighting the socioeconomic dimension of substance use among displaced communities. Thank you again for your contribution. Now, let's move on our final presentation, which will be given by Ms. İzel Yıldız from Turkish Green Crescent Society. She will join us with her presentation on building psychosocial resilience in crisis-affected youth and families. And Ms. İzel will discuss how early interventions and psychosocial support services can prevent negative coping mechanisms, including substance use, particularly among youth and families in crisis situations. Ms. İzel, the floor is yours.
Thank you. And I will share my screen right now. The screen is on, right?
Yes.
Okay. Hello, everyone. I'm the last speaker today. I hope you had a great panel today. The other presentations was very informative. My connection is all right?
Yes.
Okay.
Everything's all right.
Okay. My name is İzel, and I'm a clinical psychologist at Green Crescent Counseling Center for about 3 years now, and I will be talking about building psychosocial resilience in crisis-affected youth and families. And I will talk about today about crisis. I will give definitions, types, and those affected. And I will talk about the resilience, psychological resilience, social resilience, and importance of the resilience. And I give some rates, give some numbers from the research conducted. And I will give information about Green Crescent Counseling Center and building psychosocial resilience. Let's look at the definition of the crisis. It's a situation that produces significant cognitive or emotional stress in those involved in it. And there are 4 types of crisis. Natural crisis, such as earthquakes, floods, or hurricanes, economic crisis, unemployment, recessions, health crisis, pandemics, which we all know, epidemics, and social crisis. And youth and families affected by crisis face various mental health challenges, disruption in daily life, and long-term emotional consequences. Let's look at the impact of crisis on youth and family. If you look at the youth part of it, they have difficulty processing and managing trauma. There are a lot of stress of it. They have anxiety, depression, disruption of social bonds. They have loss and grief, and they don't know how to manage that. And development delays and challenges increase the bad side of it. There are health risk, education disruption, and economic challenges. If you look at the family-wise, financial instability, housing insecurity, difficulty managing and processing trauma as well, parenting stress and family breakdown. There are many tensions, with child and parents, coping with trauma and loss and grief as well, and there are health risks. But what is a resilience? Resilience is the process and outcome of successfully adapting to difficult or challenging life experiences, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands. Psychosocial resilience is psychological and social. We can divide it psychological and social resilience. Psychological resilience, the mental and emotional capacity to handle the stress, overcome the challenges, and bounce back from difficult experiences. And the resilience involves traits like optimism, problem-solving skills, emotional regulation, and a sense of purpose. If we move on to social resilience, the ability to maintain or rebuild supportive relationships and social networks during and after crisis. It relies on strong family bonds, community connections, and access to external resources and support systems. Let's look at a person without psychosocial resilience respond to crisis situations. The person may have excessive anxiety and stress. It may have physical symptoms and health problems. Withdrawal and social isolation, emotional breakdown, depression, anger management issues, impulsive behavior, avoidance, and substance use. Building psychosocial resilience in youth starts with physical well-being, and it move on with individual interventions like encouraging emotional expression and regulation. It is important in this part, counseling and mental health services is available around it. Providing safe spaces for youth to process trauma and teaching coping skills such as mindfulness, problem-solving skills. And peer support and social networks are very important too, fostering peer groups for shared experiences and mutual group support, promoting positive role models and family involvement in recovery as well. And access to education and skills. In the affected areas, there are disruption in the life, so accessing education and normal life is very difficult. Supporting continued learning opportunities during crisis is very important, building psychosocial resilience and offering vocational training and life skills development. And if we look at family-wise, of course, physical well-being is the most important thing. After that, parenting support, providing guidance on effective communication and emotional support, helping parents manage stress and promote healthy parenting, family-based interventions, encouraging family cohesion and bonding through shared activities, strengthening family networks, especially extended family and their community in the area. And there are therapeutic approaches, counseling and therapy to support families dealing with trauma, family therapy to improve communication and conflict resolution, and teaching coping skills, problem solving, mindfulness, emotional regulations. And as you all know, there were disaster in Turkey in 2023, 6th of February in Kahramanmaraş. As Green Crescent Counseling Center psychologists, we play a role for building psychosocial support in the area. We have a hotline, 115, provides services to clients who have addiction-related problems and questions. After the earthquake disaster in Kahramanmaraş, we supported to individuals affected by the earthquake by establishing a psychosocial support line. In the support line, there are clinical psychologists, and we talk with the clients and do the psychosocial first aid, and nearly 15,000 calls is answered. And after a short time, Green Crescent Counseling Center established a container center, and we provide face-to-face counseling in there. Let's look at why psychosocial resilience matters. First of all, mental health protection. It helps reduce the impact of stress, trauma, and adversity on mental health, preventing long-term psychosocial conditions such as anxiety, depression, PTSD, substance use. Coping with crisis is very important. Individuals with high psychosocial resilience are more likely to cope effectively with crises such as natural disasters, loss of a loved one, economic difficulties, and trauma. Promoting recovery resilience allows individuals to recover faster from setbacks and adapt to new circumstances. And community well-being. On a larger scale, community with high psychosocial resilience can collectively overcome social, economic, and political crises, building strong bonds and fostering a supportive environment. And the importance, timely interventions, and the differences they can make in long-term well-being. Here is some researches conducted and some numbers. Early psychosocial interventions following an event, natural disaster, or social trauma increase the development of post-traumatic distress disorder by 20 to 30%. And another study found that psychosocial support programs conducted after a disaster showed emotional recovery and increased resilience levels in more than 50% of participants. A study conducted on children and adolescents found that post-crisis psychosocial intervention reduced symptoms of depression, anxiety, and trauma in children by 40% to 50%. And early psychological interventions have been shown to have positive effects on the fight against addiction in individuals exposed to a traumatic event. For 30 to 40% decrease in addiction rate is seen. And family-based psychosocial interventions also show positive results. Post-crisis stress among family members reduced by 30%. And that's the last of my presentation. Thank you for listening.
Thank you, Ms. Izel, for emphasizing the importance of early interventions and resilience building in crisis-affected communities. Thank you again. As we come to the end of our session, I would like to extend my sincerest gratitude to all of our esteemed speakers for sharing their expertise and valuable insight today. Also, due to the ongoing challenges in Sudan, the representative was unable to attend. However, we sincerely appreciate his valuable contribution to facilitating this event and supporting the discussion of this critical issue. To conclusion, this discussion has reinforced the urgent need for comprehensive and inclusive and also sustainable policies to support displaced populations, particularly those facing substance use and mental health challenges. Thank you everyone who joined us today. We hope this session inspires further collaboration and action. Before the closing session, in the chat box, we have a question for Dr. Charlotte, but she answered the question. Thank you.
Maybe I can, if you want, I can come back to it.
Sure, if you have time, yes, I would love to hear.
Just 1 minute, maybe. And the question is if there are telling, is there a real life example that caught my attention of substance use among refugees? But first of all, I would like to emphasize that I think it is, we should be wary to use these telling examples to not generalize the different kinds of stories, because as has been exemplified, people with different types of migration backgrounds, different experiences might use for different reasons, different types of substances, and we should really be wary not to put one type of substance to one population group. For instance, the research we did in 2017 among refugees is largely no more representative, or was not represented at the time, also because it was qualitative research. So my recent research in the reception setting is mainly also based on professional experiences to elicit the problems that are experienced there. So I'd rather refer to the research reports and the publications where you can take a look at the analysis, the meta view that we deduct from the stories that we hear, rather than to give one telling story. Of course, for instance, the use of lyrica, pregabalin is something to look at, because we see that in Brussels, it is a general phenomenon. But aside from that, I want to be wary to link certain substances, certain situations to certain populations. Thank you.
Thank you, Ms. Charlotte. And thank you once again to everyone. We appreciate your time and look forward to future discussions. And good evening for everyone.
Bye.
Thank you. Bye-bye.